Good morning, everyone. So I'll be presenting about the cornea part of chemical injuries that we deal in our daily practice in acute emergencies. So as we all know that chemical injuries account almost 10 to 20% of the patients that present to our casualties. Alkali injuries are more common compared to acid injuries, and whenever you're dealing with any patient of chemical injury, medical legal aspect is something that you need to keep in your mind, because later on it always becomes a hassle if it is not dealt with earlier. We all know that acids do coagulate the proteins, and this limits the penetration of the acid into deeper part, while alkalis saponifies the cell membrane lipid and lead to deeper penetration and hence causes more damage compared to acid injuries. The clinical presentation can be variable. In conjunctiva, you can have chemosis, congestion, blanching, epithelial defect. In cornea, you can have epithelial defect, melting, sloughing. Also, there can be uveitis, raised intraocular pressure. The presentation may also vary based on the phase in which the patient is presented. In the immediate phase, patient presents with epithelial defect, raised IOPs. Acute phase, there is a phase of epithelial regeneration, vascularization. In grade 3, grade 4, there can be melting and ulceration. In early reparative phase, while grade 1 and grade 2 injuries show continuous healing, grade 3 and grade 4 will show corneal scarring. And in the late reparative phase, which is more than 3 weeks, grade 1 to 2 show minimal corneal changes, while grade 3 and 4 end up in corneal scarring and limbal stem cell deficiency. While assessing any patient of chemical injury, it is important to document the visual acuity, intraocular pressure, do a detailed slit lamp examination, and mention the findings on paper well for your future medical legal aspects.
Dr.
Also, a
Pranita,
double eversion of the lid.
would you mind coming to the relevant slides,
Yeah.
because the other session speakers are there?
Looking at the doers, grading and classification, this is important to know so that we can manage the patient well. In the immediate phase, and a wash of the eye for at least 30 minutes with 1 to 3 liters of fluid. The fluid being normal saline or ringer lactate would be good, and a pH check with litmus paper is essential so that you do an adequate wash. After this, coming to the medical treatment, use of preservative-free lubricant tears in the form of CMC and hyaluronate would help. So topical ascorbate and citrate will also help in the healing, reducing the proteolytic enzymatic activity and support the collagen healing. Oral acyclovir, oral tetracycline and vitamin C is helpful. Topical steroids are essential in the early phase to reduce inflammation. Topical antibiotic encyclopedics are essential. Autologous serum and umbilical cord serum AMGs is something that can be considered on case-based scenario. Topical steroid is a double-edged sword. Sometimes in the initial 10 phase, while it is essential, later phases, if the epithelial defect is persisting, you need to stop steroid beyond 10 days. Sometimes it can also lead to development of infections in the background of chemical injury, as was seen in this case, who developed an infective keratitis, and hence steroid had to be stopped, antibiotics had to be stepped up, and steroid was reinitiated only after the infection resolved. Amniotic membranes are important where there is extensive limbal involvement. As you can see in this case, there was almost nearly 9 clock hours limbus involved, which was managed well with amniotic membrane transplants, symblepharon ring and tarso, and it healed well at 4 weeks with nearly clear cornea. Tenoplasty can also be considered in patients who have significant limbal avascularity at presentation, because tenons gives you a good vascular supply. Umbilical cord serums have a lot of epithelial regenerating property because of the growth factors it has. So to conclude, acute chemical injuries in the emergency management need to be managed with a copious wash. If it's a grade 1 and grade 2 injury, subsequent only medical treatment with topical therapy can be done. If it's a grade 3, grade 4, then you need to top up with amniotic membrane grafts, and grade 5 and grade 6 tenoplasty may be considered. However, despite of the best management, grade 5 and grade 6 do end up in a lot of complication. So these are just a few cases. Funny cases can come to you. This was a female who had applied crushed custard apple seeds in her hair for her hair treatment, ended up with epithelial defect and sloughing. It is important that you debride the sloughed epithelium before you start medical therapy. This case we have already seen. This lady had an injury with a toilet cleaning acid. Now this is an interesting case of Dhatura injury. The patient developed corneal edema and endothelitis, was well managed with only topical steroid and cycloplegic therapy. This is a case which had a grade 6 injury despite of the best management, ended up with a corneal scarring, and in such cases, surface reconstruction with limbal stem cell transplants and keratoplasty later is required for optimal treatment.
Thank you, Dr. Pranita, for the quick presentation that you covered up everything, and it was a nice presentation and nice.